Okay. Okay.
Just keep going.
Just keep going. Did I just disappear? It just like went.
Yeah, I don't know what
Okay.
happened.
I don't know what happened there. All right, I'm back.
Mandy?
Yes, I'll turn the interpretation back on.
Okay, thank you.
Hang on just a second. Okay. All right, let's go ahead.
All right. Oh, can you make me a co-host again? Oh, thank you. Sorry, I was talking about intense exercise. Yes. Let me share the screen. Okay. All right, slides are back and I'm back. Sorry about that, everyone. I don't know what happened there. So, so intense exercise can be disruptive to hormones. And part of that's because, and actually low body fat for estrogen can cause lower estrogen. So, so one of the things we talk about, this is what I was saying, when we do our sports physicals in women is, you know, when was your last period and how regular are your periods? Because it is not uncommon for intense or professional female athletes to stop having periods. And that just shows how kind of disrupted the hormones are. Okay, so menopause. So menopause will affect everyone. This was our hot flash. You know how you have no idea how freaky it is to live with menopause. And he says, don't I? So it will affect all of us. It will affect everyone. Hot flashes that we talk about, and it's this intense feeling of heat in the face. It can cause a kind of flushing or reddening, and you may have seen this or experienced it. But you know, neck gets really red, face gets really red. It can come out of nowhere. Heart speeds up. It often happens at night, and so that's part of the problem with, or part of the cruelty of menopause, is that it really can be disruptive for sleep. It can cause sweats and then kind of cold chills. When we talk about menopause, the average age is 52, and the best predictor is when your mom went through it. But we don't have a good test for exactly when you're gonna go through menopause. And menopause is defined as you have not had a menstrual cycle for 12 months. And so the age range, the age of menopause can range a lot, and it can range from 35 to 55. I mean, it can be a significant, you know, people can start early, like we talked about. And this is the good news, is the symptoms of menopause could last 10 to 20 years. That's not what everyone experiences. It can be shorter in some people. But the idea that you could spend, you know, almost half of your life in menopause, and that you could spend a decade or two with menopausal symptoms does not sound great to some people. The symptoms of menopause, you'll see these look a lot like our low estrogen, because that's what's, you know, driving this. It's the hot flashes and night sweats, anxiety, mood swings, irritability, can affect memory. And so people can, you know, people will often complain of, you know, just not feeling like themselves, feeling like things are off. You can have, of course, the sleep problems, depression, decreased libido or interest in sex. You can have hair growth, panic attacks, weird dreams, urinary tract infections, low back pain, bloating, osteoporosis, like we talked about, aching joints, and hair loss. So how fun does that sound? We all want to sign up for that. Perimenopause. So thankfully there's things we can do. Perimenopause, we don't talk about a lot. Perimenopause literally just means that time, or kind of that transitional time. And this can last 4 years before menopause starts. And it could go up to 8 years, but it really is, it's when hormones start to change. When FSH, which is this, one of the hormones that triggers estrogen and progesterone, as that starts to rise and your periods may become a little less regular, that can be the start of this perimenopausal time. But in this perimenopausal time, hormones are going down and hormones are dropping. And so this is the time when sleep can be affected, people can feel more anxious, and hot flashes are common in perimenopause. And so people will feel like, gosh, I'm still having my period, but why am I having this flushing, or why am I having hot flashes? This could start as early as age 40. And then some of the mood part, so the mood changes, the anxiety and the depression can actually be strongest in this perimenopausal time. So as we're having this shift in hormones, than in the premenopausal or even the postmenopausal time. And that perimenopausal time, when you haven't stopped having your period yet, your estrogen level may look normal, although you're having those symptoms of hot flashes and low estrogen. So hormone replacement. So we do have a way to help with menopause. It is safe in most women. We'll talk about that. That's my next slide, is safety. There are multiple ways to replace hormones. And so let's talk about that. So for some hormones, you can take them orally, you could take them as a pill. So that works for estrogen and progesterone. It doesn't work for testosterone. It works for thyroid. It doesn't work for insulin. And there are creams or sprays. And so a lot of time for estrogen, we'll use a patch. We'll use a transdermal estrogen replacement. What we found with transdermal versus oral is that oral estrogen has more side effects and more risk of raising blood pressure and blood clots than transdermal estrogen. And so we tend to go more towards the transdermal estrogen. You can also have it injectable. So that's what insulin is. That's how testosterone is given a lot. Estrogen will also use a vaginal, either a cream or a tablet, to replace estrogen. What's nice about that is that we can really localize it for some of the vaginal symptoms that come with menopause, but it's a much smaller amount. And so this is something that could be safe in somebody even with a history of breast cancer, where we don't want to use kind of a systemic estrogen. But if we just wanted to have localized benefits, then you could look at vaginal estrogen. And then implantable. And so people may know, other people who've had this, we have implantable birth control, but they also have pellets that for bioidentical hormones. And this has become more and more popular lately. But what those are they'll create a pellet that has, and usually it has estrogen, progesterone, and testosterone in certain amounts, something that's been kind of tailored to you. And then they will make a small incision, usually in the top of the buttocks, and they'll insert that pellet there. And then that will slowly dissolve over a period of time. And so it can be somewhere between 4 and 6 months, and then it would be replaced. The nice part of that is you don't have to use a cream every day. The downside of that is if the dose is wrong, you have 4 months to wait till that gets out of your system, because there's no kind of going in and retrieving that. Hormone replacement, we talk about it, we could do it for 5 years, but you could go up to 10 years with hormone replacement in a safe way. And talking about after menopause. Really, we think of it as, if you're doing it in your 50s or early 60s, if it's 10 years after menopause, then that's a safe time period to do it. And the goals are both, the goal, why would we replace hormones? And the goals are reducing those symptoms that we've talked about, as well as protecting against osteoporosis. Just a note on progesterone. So you can do progesterone either as a topical or as a vaginal or as an oral. But a lot of times we'll actually use the oral progesterone. And so because it's a little bit relaxing. And so people will do an oral progesterone at nighttime because it's a little bit calming and a little bit relaxing, because remember, we talked about low progesterone affecting sleep and making people feel more anxious. And so the replacement actually makes people a little bit drowsy. And so we give that at nighttime. So this is the big question, kind of about hormone replacement. When I first started, and the Women's Health Initiative was already kind of out, and things were starting to switch, which is, in the past, they would give hormone replacement therapy, HRT, to everyone. And as soon as you kind of went through menopause, and they would continue it for a long time. And I've had many 80-year-olds and up to 90-year-olds that I have tried to wean off of their estrogen, and they hate it. And when they've been on it for that long, it makes people feel better. And so it can be really hard to give up. And so as long as anyway. So I have fought and lost those battles of trying to get people off of estrogen when they've been on it, for 30 years already. And then we just try and be safe about it. But so the breast cancer risk, when they did this Women's Health Initiative, they stopped it early initially because they saw this increased risk of breast cancer. They were testing people with just estrogen by themselves, and then a group that had estrogen and progesterone. The progesterone they were using is a type called progestin, which is a synthetic progesterone. As they've gone back, and so that initial thing is what really caused everyone to kind of go away from hormone replacement for menopause, and the pendulum really swung towards not giving it to anyone. Since then, it has come back to this kind of middle ground where, and as they've looked at things, what they found is that estrogen by itself did not cause any estrogen by itself, with a median time of around 5 years, did not cause any increased risk of breast cancer, and may have actually decreased some risk of breast cancer. What seemed to increase it was this synthetic progesterone called progestin. And so, and there's no signs, or there's no evidence that says that progesterone, kind of the bioidentical version of progesterone, has an increased risk of breast cancer. So where we are right now is the feeling that definitely doing estrogen for 5 years after menopause is completely safe, and people will go up to 10 years and feel like that's safe. And there does not seem to be an increased risk even in that time period. But I would stay away from a replacement that has progestin, because that has been shown to increase risk for breast cancer. So I use that term bioidentical hormone. So bioidentical versus, well, I don't know why I put standard. I should have put synthetic, but the bioidentical just means that the structure is exactly the same as what your body makes, or what your body already has. We have for estrogen, for example, we have bioidentical estrogen, which we call estradiol. And then we have kind of conjugated estrogens, which are equine estrogens or come from horses. The bioidentical has also this other kind of meaning, which it doesn't have to be this, but often bioidentical means, or what people think of when they hear bioidentical hormones is you see a specialist for that. They compound your cream or your pellets, and so that you're not using kind of standard FDA approved medications. But that it doesn't have to be that, because there are brand name medications FDA approved that you pick up at the pharmacy that are bioidentical for estrogen and progesterone. Testosterone. So we don't need to talk much about testosterone. It is still important in women. It's still it contributes to a sense, although it's just less of it than in men, but it contributes to a sense of well-being. It helps with energy levels, and it helps with muscle retention. Another thing I inherited when I took over my practice 16 years ago was a woman who was on a rather large amount of topical testosterone and was a female bodybuilder, but would come in and talk about it just for mood and just for libido. And at a point we had to kind of cut that off, because it became clear that I was helping her juice for her competitions in bodybuilding. And I didn't mean to be doing that. The other thing is all men's testosterone will decrease with age as well. And so we call that andropause, is that starts to decrease in all men as we age. So that's kind of our sex hormones, and we're doing okay on time. Let me talk about thyroid. Thyroid is the great imitator. Thyroid hormones affect every organ system in your body. They control metabolism and energy. The two main ones are T3 and T4. And thyroid dysfunction is pretty common, especially in women, more so than in men. And we probably all kind of know these symptoms. So I'll talk about low thyroid and high thyroid. You know, low thyroid people, you think of everything slowing down. So you feel cold when other people feel normal. You feel tired. You have weight gain or difficulty losing weight. You can have dry skin or hair loss. You can have poor concentration. And low thyroid looks a lot like depression. And so when we're seeing somebody for depression and thinking about starting medication, one thing we always do is check thyroid, because that can look a lot like depression. High thyroid is the opposite. High thyroid, it would be great if high thyroid was like this, just feeling like revved up and ready to go. But high thyroid is really unpleasant. High thyroid, you feel hot when other people feel normal. You can have this racing heart or palpitations. It's difficult to sleep. You have weight loss. You're jittery and anxious. And you know, when it's severe, you can even have these bulging eyes that happen from high thyroid. Thyroid is pretty commonly tested. I would say the one thing that the TSH is really commonly tested. We test that in it's probably part of everybody's physical. The one thing I'd say is that there may be some benefit to looking also at free T3 and free T4, your other kind of thyroid hormones, just because TSH can have this big range. The other thing about TSH is that TSH stands for thyroid stimulating hormone. And so that's the hormone that comes from your brain to tell your thyroid to make more. And so it's backwards, so that when TSH is high, it means your thyroid is low. Or if TSH is low, it means your thyroid is high. The other thing we look for is thyroid antibodies. That's to see if your body's is actually attacking either thyroid hormone or attacking your thyroid. That's the most common cause of low thyroid. Thyroid replacement is really common, and lots of people are on thyroid replacement. Our most common is a synthetic, like Synthroid. A synthetic, it's T4 only. There are also thyroid replacement that is T3 and T4, and those come from pigs. And that's called like Armor Thyroid and some other things, or Nature Throid. So there are different things there. Thyroid's another one where we'll run into this kind of debate of, hey, we're replacing your thyroid. Is it enough just to get you into the normal range, or would you feel better more in the middle or at a different point in that? And you'll find different opinions among doctors, but that's something to kind of have that discussion, and you can have that discussion. Insulin, insulin we think of mainly because of diabetes. Insulin is a hormone that goes up when in response to a rise in blood sugar. Type 1 diabetes is a lack of insulin, and so their pancreas stops making and secreting insulin. Type 2 diabetes, and so their insulin is really low. What we'll get from that is people with low insulin are very thin. You lose, you can look a little bit kind of thin through the cheeks because you don't have much body fat. Type 2 diabetes isn't a lack of insulin. Instead, it's you've lost that sensitivity to insulin. Your body's resistant to insulin. And so insulin actually could be high. And so those people, the most common with that is they have extra body fat. And insulin is a hormone that can contribute to fat deposition. And so we think of that, and that's part of why, we see weight. That's part of why the low carb diets can help with losing weight, is because there's less insulin in that. Next is cortisol. So cortisol is our stress hormone. We call it that. It has a really important function. Cortisol is made by your adrenal gland. It's actually structurally the same as hydrocortisone. So when we talk about hydrocortisone as either a medication or as a cream, like that's the most common way we use it, that's structurally the same thing. So cortisol is a steroid. And like all steroids, it decreases inflammation, and it decreases, and because it decreases inflammation, it's also decreasing immune function, right? It increases sugar and it increases energy, and it's meant to kind of get you going. And so people's cortisol is highest in the morning, and then kind of lower throughout the day, which is what it's supposed to do, because it kind of revs you up in the morning. Where we see this, and where something that kind of that's interesting to think about would be, I worked in student health for a year at the University of Missouri, and you all know this, but how many times did I see students who were finishing a week of finals, and they've been super stressed, and at the end of that they get sick, right? Or if cortisol is like maintained high, it's lowering your immune function that entire time, right? And so that's one of the ways that we think stress can be detrimental for people. Cortisol is important, but like everything, there needs to be balance in that. So too much cortisol is problematic. Also, we think of it too with that sugar part, right? Is that when we test people's sugar, and we test people's sugar in the morning, stress can affect that as well. You're kind of you're fasting sugar in the morning because cortisol is meant to increase that. So if you're super stressed, that'll be higher. All right. So I did want to just, because we went through those things, hormones can be really related to weight, right? And we all kind of know that, but all of the ones we've talked about, estrogen can affect weight, progesterone, thyroid, and cortisol and insulin, all of those can be kind of implicated or can change your weight. And so if people are having trouble losing weight, then definitely it's worth looking at your hormones and kind of exploring that. As in all good things, the key is balance, is trying to find those places where your hormones are in balance, and that your symptoms are kind of low, and you're feeling good. And yeah, and I think that's what I would leave you with. This is the end of the presentation part, but what I would end with is just the idea that I hope this gives a little bit kind of that primer of how important hormones are, how many effects they have in the body, and how important it is to have those in balance. And that if you're feeling some of those ways, that I think it's worthwhile going and talking about it with your doctor and getting that tested, so that you can see, hey, how can I get that back in balance? It doesn't always have to be hormone replacement. Maybe it's lifestyle changes, and maybe it's changing diet, or maybe it's exercising even less, those kinds of things, to get hormones back in balance. So thank you all for listening to that.
Thank you so much.
Thank you.
Okay, let's do this. I know there's a couple questions in the chat. Amy Fritz was going to kind of monitor the questions, if you want to do that, Amy. And if you have a question, go ahead and put it in the chat.
Sure, I'll just read them out. So about hot flashes, do they ever go away? This sister is 65 and still has hot flashes and night sweats.
So that was part of that. It can last 10 to 20 years, right? Is that it, for some people they go away, and everybody's different, but for some people they seem to last a really long time. And so that can be really frustrating.
Okay, thank you. The next one is, do you have any recommendations for PMS or PMDD when hormonal birth control is not an option?
We've seen, I've had really good kind of success with low doses of Prozac and low doses of Paxil, actually. So we have antidepressants and actually for Prozac, I've used it both as a daily medication, but also I've had, and there's been good studies for this, that even low dose Prozac just around, for 2 weeks out of the month has been helpful. And so I've had a couple patients where that's been really helpful.
Okay, what if you go several months without a period and then it comes back? Does that put you in the perimenopausal time frame?
Yeah, I think it would depend on age, because we've all seen it where, I don't know if we've all seen it. I say that I've definitely seen it where women have been super stressed for some reason, and their period stopped for a period of time, and then it came back. But I think if you're in that, kind of 40 age group, and it's become, and you might be skipping or it might be lengthening, then I think that would be a time I'd say, hey, that could be menopause.
Okay, and what about an E-string?
E-string is another way to get, right? Oh yes. So that's the vaginal ring that has estrogen embedded in it, right? And so we've had, it's just another way to replace it, but I think it's a helpful one. I think it's a good way, and people like that.
Okay, where can I find statistics for average for people who are within a certain weight category and active? It's very hard to determine where I should be within the typical 95%. So I would like to have the average category broken down into a category relevant for me. Is there such a thing?
That's a good question. I don't know about where you could find that. I do feel like, again, and I think we find that just like we were talking about the labs of, hey, this is a certain group that falls within these two norms, you know, but where you are in that, you know, may be off. I think BMI has a lot of problems with it. And so we use, you know, we tend to use BMI in medicine and body mass index as this measure of kind of what your weight should be. And I can't tell you how many people, how many patients I have that feel like that just doesn't apply to them, you know, and that it's an unrealistic place to be. And so I do think there are things we can do, but I don't have a good reference for that. That's a good question.
Okay, here's another one. I've been 10 years in menopause, so would I still be eligible for estrogen therapy?
So kind of, that's up to your doctor. That's up to your doctor. Because I do think there may be situations where that's appropriate, and there may be situations where we say, hey, that, you know, we can do it, but know that there's some increased risk, or you start to kind of taper down. But at 10 years, that starts to run into that place where we say we're a little less confident about the safety of it in terms of breast cancer.
Okay. I've got a question, Alph. Do you feel like, I know in some areas of women's health, like we just haven't done enough research on women still. Do you feel like there's been enough research, like we have a lot of good information, or do you still feel like there needs to be quite a bit more?
Oh, I think there needs to be quite a bit more, you know, and I do think medicine is kind of notorious for underrepresenting women in studies, right? Is that, and even there are some cases of female hormone studies being done in men in the past, you know, I mean, it's just kind of ridiculous. And so I think this is a perfect example of a place where we could use a lot more. And it feels, and I feel a little bit like that's why there's some of these controversies, and there's why there's, you know, we don't necessarily have good information, is, you know, we really rely a lot on this Women's Health Initiative, which is a huge study of 23,000 women, but we need more.
Here's another one. Are those pellets covered by insurance? Do you know?
No.
Oh.
The pellets are definitely not covered by insurance. And so, you know, there are people in Walnut Creek that do those. What would the price be? It's probably like, I don't want to get it wrong. It's probably the $400 to $500. But I guess they think of it as, hey, this is spread out over 4 to 6 months instead of, you know, having to pick up a prescription every month. But it's probably in that range.
Okay, that's kind of all that are in the chat. So if anybody can think of anything else, get it in there. Let's see. Okay, good, well done. Okay, what are your thoughts on progesterone creams?
Oh, I think progesterone creams can be good. And people can really feel, I've had patients who had, from dealing with their low progesterone, felt like their life changed when they got on progesterone creams. And so I think it can be really helpful. Yeah.
Okay, and then your thoughts on plant-based estrogen.
All right, before I get to that one, the other thing I failed to mention about progesterone is that one of the times we think it's essential is when, and I didn't mention this for some reason. So in that menopausal hormone treatment, if you still have a uterus, then we definitely want to use estrogen and progesterone. And that's because the risk of uterine cancer goes up if you're just using estrogen. And so we think of that as, you know, if you still have a uterus and you've gone through menopause, but we're giving you estrogen, what we call unopposed, meaning without progesterone. If we just give estrogen, then that just builds and builds the lining of the uterus without kind of any stop on that or without any control. And so there can be an increased risk of uterine cancer with unopposed estrogen if you have not had a hysterectomy. So if you still have a uterus. So everybody with a uterus should definitely be having both of those if they're doing hormone replacement after menopause. And then the plant-based estrogen. So estradiol, so are bioidentical, are plant derivatives. And so I think those can be really helpful.
Okay, we've got a couple more. How do you feel about the ablation procedure that burns something inside to stop periods?
Yeah, so that can be, yeah, so the ablation can be either with, sometimes they do it just with like really hot water. So this is putting some form of heat inside the uterus, and this kind of relates to what we were just talking about, right? So if you have a uterine lining that has grown so much that you're having really heavy periods or can't stop bleeding, then doing an ablation where they just take that down with heat, that can be really helpful for people. It's also not permanent, you know, but it's something that can be really helpful.
This one, while I read it, you might want to look at it in the chat, Alf. It says, diagnosed with low thyroid, prescribed levothyroxine by Kaiser. Basically, they say we'll have to take it all my life, but never looked at if it's related to T3 or T4. I don't think Kaiser cares as long as the thyroid number gets to where it needs to be. Isn't there a way to figure out what causes it and possibly change it with diet?
Yes and no. And first of all, I'm all for bashing on Kaiser because that's where my brother lives or works, right? And so I'm all for like making fun of Kaiser. Yes, they're the worst over there. No, just kidding. So Kaiser doctors could be really good. But definitely it's a big bureaucracy. So sometimes it feels like you have to definitely advocate for yourself there. So that question was, typically if you're diagnosed with low thyroid, then it will usually be both T3 and T4. We give levothyroxine, which is only T4, but your body converts it to T3. And so that's how we replace it. And so usually that's enough to get it back into the normal range. But I agree that a lot of times they don't do the test of, hey, do you have thyroid antibodies or what's causing it to be low, which can be helpful. And so I do think it's worth having more of the thyroid levels drawn and looking for what the cause is. But sometimes even when we do that, there's not a way to like correct. We would love it if we could correct it with nutrition or with other things. A lot of times, because the most common cause is that autoimmune, your body's attacking the thyroid, and the only way we kind of treat it is by supplementing with some form of thyroid, either the levothyroxine or Armour thyroid, which we talked about, which has T3 and T4 in it. So yeah, it definitely is worth talking to your doctor more about.
Okay, and do you recommend a hysterectomy for abnormal hyperplasia?
Oh, that you would have to talk to your doctor about. That feels very, I think it would really depend on like where it is and what's going on, but definitely talk to your doctor about that.
All right, and then there's a recommendation for someone also. I think we've done it.
Oh, Bonnie Kimmel, I'll second that. I'll second that. Kind of endorsement of Bonnie Kimmel. So yeah, Bonnie Kimmel's great. She's an endocrinologist at John Muir, and we've worked together. She's great.
All right.
Okay.
Thank you so much, Alf.
Yeah, thank you. That was fun.
Thank you so much for being here. Thank you everyone for your questions and for being here to watch. And we just are so grateful to have you in our stake. And the Lafayette Ward is especially lucky to have you. So thank you.
Thank you.
All right. Thanks everyone. Good night.
Thank you. Good night.
Good night, everybody.
Thank you.
Yeah. Good night,
I did hear
everyone.
one.
Thank you.
I did hear one funny thing on hot flashes from when I started having menopause from a good friend, and she said, just remember, hot flashes are just your inner child playing with matches.
Very good.
Yes, that